because to me it's lost if we don't capture it, because I'm thankful we've had them this long, and we would love to have them another 20, 30, 40 years as well. But the reality is, we just want to make sure that we capture that history. What we're also doing is making history now, though. What do you think about their talk?
I loved their talk. I actually forgot some of the history. I've heard it for many years, but I've forgotten a lot of it. But then to see those pictures and to see people that have gone before us from our family and to carry their legacy forward is really cool. You remember a lot of different moments from conferences of St. Petersburg, San Diego, Milwaukee, so many different areas that we've been to, and there's so many memories in each one. So I'm excited for those of you that are new this year, that are making your own memories in, where are we? St. Louis. Whew, it's been a day. St. Louis, and then to take these memories elsewhere. It's really, really cool. Speaking of memories, because we were talking about this last night, if you guys are taking pictures,
yes.
Any one of you, please, please, please tag us online, Instagram, Facebook, maybe Twitter, not TikTok.
Not yet.
But also use the hashtag, or for those of you that are not savvy with the internet talk, pound sign.
Really old school's number sign.
Hashtag Oley 2023. It's very simple. If you're at home and you're watching and you want to take a selfie with your computer, live your best life. That would be awesome. But also tag that hashtag Oley 2023. We can pull those up and we can start to see where everybody's watching and taking pictures from. If you're taking pictures in front of the 80s wall, of a clinician, whatever it may be, we want to be able to go back and look at what Oley 2023 has been and where you all were and why you weren't in this room.
Yeah, for sure. One of the things we're going to be doing this morning after a couple of general sessions is we're going to do something that some people love and some people are it's hard to watch, and that's in loving memory. And so we actually do a slideshow, kind of like the Oscars or whatever it is, those who've passed this last year. It's a reality in our world. It's a reality in our world that there will be some. Some of us are living our best life, and then like Dr. Darlene Kelly was a very long time advisor to Oley, board member, then advisor, then she came on as part-time staff, and she retired just last year and suddenly passed this year, and we're all just devastated. So what we do is we put together a slideshow, and we just kind of remember and reflect on those people. It may have been this last year, or it may have been years ago, and it's a time to kind of even reflect on our own mortality. The first talk today, in fact, is going to be about transitions of life, and it's mostly the other kind of transitions, like birth, to home from hospital, or to teenagers, to, those next stages. But that is something, and we don't want to dwell on it, but we do want to honor that. And one of the things that I was hearing from feedback is that the slideshow over the years is how many people are not with us anymore. Did you have that feeling?
Yeah, I mean, it's, like I said, it's beautiful to see those memories and to remember those people. I've met some of my best friends in these rooms and in these sessions and playing Ding Dong Ditch in hotels. I'm really sorry if that was any of you. But we made some great memories. We have some hilarious stories. I think our parents have more hilarious stories of how we all met and where we all met. Some of us met because we had an accident, we were both ended up in the bathroom, like whatever it may be. So it's very interesting to go through these slideshows and see who's gone before us, and then to think, like, do we still keep in contact with their families? Do we keep in contact with other friends that we were part of the circle? So it's hard. Also, feel your emotions. I think that's something that we don't express enough. You might see people that you didn't know past, you might see people that you did know. It's okay to feel that. Every time I see a picture of a specific person that has passed, it always gets me. So feel that. It's okay. That's our history, that's our journey, that's our story, that's life. Feel those emotions.
Yeah, and it's okay, and we don't dwell on it, but it's something that we want to talk about. And then this morning was very specifically crafted. I hired new people, right? I'm a caregiver. I hired somebody that's a dietitian, a clinician, and I also hired somebody that's a long-term patient, right? And so the three of us even will sit down and do a lot of brainstorming as what should sessions be from all the different ones. The industry folks haven't been on that conversation yet, and I want to fix that too. They need to have a seat at the table and a voice at the table. But at the end of the day, it's the clinician, or it's the caregiver consumer that has the final voice. And we heard very loudly and clearly that mental health is one of them. And we're not allowed to talk about that as much as we need to. And so this morning, the first two sessions are talking about transitions and some of those psychosocial things, and we're talking about mental health and how it affects us. And sometimes we don't even let ourselves feel it, so we don't know how to tell clinicians about it because we haven't even, like, I'm too busy trying to survive. I'm not working on that. So Maslow's hierarchy of needs, self-actualization is way high. I'm working on, survival today. So we do want to honor that today. So that's some of our sessions. But just wrapping up here really quickly is last night, who here attended the fashion show? Okay, who would like us to keep that next year and do that again? Wasn't that fun? It was one of those things that we weren't sure if it would work or not. And then when we heard the people hooping and hollering and the kids running down and the people showing practical ways of wearing their pumps and just living life, we realized this is something, we've hit on something and we need to keep that. So that was pretty amazing.
I passed two moms and they were crying. I won't reveal who you are because I think you're in the room. And I thought something was wrong. I was like, what's wrong? And they're like, nothing, it was so good. Just like sobbing. But I think those are what the new things here do, is that they kind of, that's how things are birthed here. We just kind of fly by the seat of our pants and then they become traditions. So it's cool.
Well, another thing we added this year was the roundtables. And, we've gotten some good and some not so great feedback about that, and we're going to take that. So one of the great things is that we had the time to sit and to discuss and to ask questions and interactive, and that was amazing. We also heard you that just says it was a little hard to hear sometimes, and maybe we do fewer of them, maybe we spread them out better, but those kind of feedback things, I need them written down. The good, the bad, and the ugly. Can you please send that to us so that the things that we did well, we want to replicate it, the things we could improve on, we want to do that. So that was kind of cool, but I'm going to share one really quick experience that happened yesterday. So there was a sibling session, right? And so my youngest is the one that's on nutrition support. So who's taking care of him while I'm here? His siblings, right? And so I thought that should be the session I go to, right? And in the middle of this, and I'm asking questions, I get a text live. From one of the siblings saying, Manny's having problems, can you FaceTime us? So I did. So I said, excuse me, I have to go do what we're talking about here and take care of the siblings who are taking care of the person. That literally happened yesterday, right? And also during the roundtables, I saw somebody, again, walking out with like almost tears. They had this look of horror on their face, and I thought, who made you cry? I'm gonna go beat them up, right? Like that's where I was putting on that hat. And I said, are you okay? And they said, no, we're not. Her line just broke. That was during the roundtable. So this is our life, right? And so we helped them get to the right place, and I haven't seen them yet this morning, so I don't know how they're doing and all that, but like that literally happened during roundtables yesterday. So talk about real life lived experience, right?
We have a couple of people that are currently admitted that were here yesterday and had to go. So that's life. It really does happen.
Absolutely. So just a couple little quick housekeeping things here is on the tables you'll see this. This is for everyone. You don't have to have long-term chronic vascular access in order to take this. This is from one of our partner associations, Association for Vascular Access, and it's just a really quick about peripheral IVs. They want to ask some questions about peripheral IVs. So if you've ever had one for a CT, you've ever had one in a hospital, it doesn't matter, central line, peripheral, they want to know about your catheter. So take the 5-10 minute survey, please, and they'll share with us the results of this. I'm looking forward to seeing what it is. So feel free to take that, and we appreciate that. And then I just want to say very quickly is the exhibitors, thank you for being here. And I've said that a whole bunch of times, but seriously, I went around the exhibit hall this morning asking for feedback. I want to do that. And we also have a couple little hiccups regarding that. And so there's some rules and guidelines that we follow in here, and I'll have you guys refer to that. But what we want is, right now I want to speak to the families and caregivers, is if there's some inappropriate behavior by anyone, please let us know. And we tell you what the inappropriate behavior is and things that are beyond the guidelines. 99.9% of them have been doing great, but there's always one that pushes the envelope and things like that. But we can't know unless you let us know. So We can talk about that more, but we have these guidelines because we need you to protect the integrity of the conference. So thank you. Again, 99.9% of you have done an amazing job and followed every single rule and are thankful for being here. But we need feedback if they don't play fair, if they don't play nice. And that's for anybody. If a patient is bullying you, if a clinician, if you don't feel comfortable in any area, we just need to know. So give us that feedback. Yeah, we'll take care of it, right?
Yes, yes.
So just really quickly is we're going to transition to our very first speaker. She's not here. But we found a way through technology and our amazing AV crew. Can we give a hand to our amazing crew? They stepped it up big time in so many ways. They have saved me so many times. I can't say thanks enough. And I also want to say thank you to all the volunteers who've gone above and beyond. I want to say thank you to my staff. And I want to thank the hotel staff too, because amazing job. And let's give all of them a round of applause as well. But this morning, so Dr. Sivan Kinberg is a gastroenterologist. She does primarily peds, but she also does transition to adults, because that we all know, if you've experienced that, there is no transition for most people. And she's working on doing that for her patients. She wanted to be here, and flights just could not work out this morning to be able to be here. And so we're going to have her Zoom in, and she's about to speak right now. And she's going to be talking about the transitions of life. So please put your hands together for Dr. Sivan Kinberg.
Thank you so much. I hope everyone can hear me. I'm going to share my screen. As Beth said, I really wanted to be there in person, and unfortunately, my transition from New York to St. Louis got interrupted by the weather. But again, thank you so much that we were able to make this work. So today I'm going to be talking about continuity of care and how we can streamline some of the transitions that occur in short bowel syndrome. So these are my financial disclosures. And these are going to be our learning objectives for this morning. We're going to talk about the different transitions that occur throughout life in short bowel syndrome. We'll touch upon some of the challenges and complexities that are involved. We'll explore strategies and best practices to optimize these transitions of care and enhance our ability to advocate for improved transitions. So just to start off, what are transitions? Transitions represent significant changes that people experience throughout life. And this can involve various aspects such as health, different care settings, education, relationships, and life stages. Transition is a process, and it involves navigating through these challenges, making adjustments and adaptations as we move from one phase to another. And this requires planning, effective communication, and support throughout the process. Each transition will be different, and we have to have different considerations and strategies to try to overcome the challenges and ensure a smooth transition and successful outcomes with improved well-being. And these are the overviews of the 7 transitions that I'm going to talk about. So we'll talk about the first transition, which is from being healthy to having a chronic illness, and then going home, entering school, becoming an adolescent, and becoming an adult. And then we'll touch on some of the transitions that occur throughout the process of intestinal rehabilitation, and we'll touch on end of life. So I like acronyms and mnemonics, so we're going to use LIFE. The L is going to stand for linear. As we all know, life follows a linear path. We can think of life as a series of dots, and all we have to do is connect them. And as long as we plan, everything will go as planned. Time out. I'm so sorry. That does not sound right. I'm going to start that over. Life is not linear at all. Life is not connect the dots. Life is more like chutes and ladders. There are going to be times that we stumble. Life is complicated and life is messy. And there are going to be rocks and meteors that are coming our way that we have to dodge, kind of like a game of dodgeball, which I absolutely hated as a child. And we have to be careful not to let these rocks crush us or flatten us. We have to learn to overcome the challenges throughout these transitions in life. and emerge stronger on the other side and find the good in these transitions and these challenges. I'm going to get a little bit more philosophical here just for a minute. This can be a discussion for weeks. What is the meaning of life? But I'm just going to touch upon a book that I think is useful. And this is called Life is in the Transitions. So this is a book that was published in 2020 and is actually on the New York Times bestseller list. And I'm going to share a quote with you from the book that I think can help guide our discussion this morning. What is the meaning of life? Life is a story you tell yourself when you celebrate an achievement, when you rush to the hospital. It's a story of who you are, where you came from, and where you dream of going in the future. It's the high point of your life, the low point, the turning point. It's what you believe in, what you fight for, what matters most to you. It's the story of your life. Life is a story you tell yourself, but how you tell that story. Are you a hero, victim, lover, warrior, caretaker, believer? Matters a great deal. How you adapt that story, how you revise, rethink, and rewrite your personal narrative as things change or go wrong in your life matters even more. So I'm going to redo our mnemonic of life. L stands for learn. You need to learn about short bowel syndrome, learn what the transitions are. And L can also stand for living every moment, laughing every day, and loving beyond words. I stands for individualized. We know that everybody has a different path on this journey, and what works for one will not work for someone else. As we overcome these challenges, we need to find our inner strength. F stands for flexible. We have to be flexible as things don't go as we planned, and we do have to adapt along the way. E is for embracing the present, embracing the transitions, embracing the challenges, and embracing the support. And that is why we are all part of the Oley, right? E is for equip, and that is our job as clinicians to equip you with the tools that you need to overcome the challenges and to empower you to succeed. So I'm going to introduce you now to my friend Gutsy. Who is Gutsy? So Gutsy might be a full-term baby that was born with ileal atresia. Gutsy might be a premature infant that was doing well for the first few weeks of life, feeding and growing, suddenly developed necrotizing enterocolitis and was diagnosed with short bowel syndrome and now needs TPN. Gutsy might be a teenage girl whose biggest concern in life up until now was what to wear to an upcoming party. And then on the way to that party, she is in a car accident and she loses a big portion of her bowel. Gutsy might be an adult who was busy living life, working full-time, 3 kids, went in for a routine surgery with complications and is now dependent on PN. So Gutsy is going to help us as we think through this journey and through these transitions. So the first transition I'm going to talk about is a transition that occurs from being healthy or expecting a healthy child to having a chronic illness. And I think it's really important to take a minute and recognize this as a transition because this is often overlooked. So what are the challenges that might occur during this initial transition? We know there's going to be emotional and psychological challenges. We now have to adjust from a healthy state or expecting a healthy child to now having to live with a chronic illness. And this can lead to emotional stress, fear, grief, isolation, and a loss of identity. Most of you have never heard of short bowel syndrome before you or your child were diagnosed, and that is because it is a rare disease. We have to cope with the impact of the chronic illness on our daily lives, how this will affect our relationships, how this will affect the future, and that can be very overwhelming. There's self-management and treatment adherence challenges. We as clinicians are expecting you to now overnight become nurses and doctors and learn how to manage your condition, understand the treatment plans, know how to give the medications, how to give formula through feeding tubes, how to give PN, how to make your lifestyle modifications, how to recognize warning signs and precautions. We know that this is not easy. Navigating the health system is another challenge. We can be honest, the health system is a mess. It's complex. There are insurance coverage issues. There are shortages. Every week it's something else. And there's lack of coordinated care. So what can we do to get you to thrive? What are some strategies to overcome this initial transition? We can provide you with emotional support through therapy, counseling, or support groups, making sure that you're taking care of yourselves, making sure that you're managing your stress and that you're coping, providing you with education on the emotional aspects, not just the physical, but the emotional aspects of living with a chronic illness, and validating that it's okay to be upset about this, it's okay to feel stressed. What can we do for self-management and treatment adherence? We can provide you with comprehensive education on short bowel syndrome. Provide this over and over again using a combination of different educational formats, written materials, videos, interactive sessions, and foster a patient-centered approach, so empowering you to actively participate in your care and make informed decisions. What can we do to navigate the messy and complex healthcare system? We can try to provide clear and concise communication about your treatment plans, making sure that you understand them, and try to have somebody as part of our team help you navigate the process. So help you make appointments, help you navigate insurances, transportation, and coordinate care. The second transition I'm going to talk about is a transition from hospital to home. And this is always an exciting transition, but it's also very overwhelming. So you've been in the hospital, things are going well, and now you're being told it's time to go home. What are the challenges that we experience with this transition? So now you have to manage your condition or your child's condition independently after going home. There's nutrition management involved, so managing the parenteral support, the TPN, feedings, different dietary restrictions, giving medications, monitoring for complications, navigating home healthcare services, and coordinating all the follow-up appointments. So what can we do to help you through this process? And in reality, what ends up happening in most hospitals is that the team will round, you're told, okay, we can go home on Friday, and it's now Wednesday. That doesn't work. That is not how we need to do things. This is a slow transition. I want you to, that's the biggest takeaway from this talk, that all of these transitions have to be gradual. So we have to start the discharge process early. And this discharge process can take several weeks to set everything up, make sure that you are comfortable going home. Have family meetings. If they're not offered to you, ask for them. And you can have these as often as you want. So have one early at the time of diagnosis. Have one after a few weeks. Have one as soon as the discussion of going home starts. Having a family-centered approach. There is a shift now in training of residents and fellows to really involve the family on grounds. But that's not always done. So if you're not being involved, ask to join the rounds, listen to the team presenting your child or yourself, learn the terminology, and participate. No one is going to know your condition or your child's condition better than you. And we need to hear from you. We want to. Make a list of questions. Make sure that you're asking them. Things can often be overwhelming and you can forget what you want to ask. So just keep a list of everything that wasn't answered and make sure that we are answering any question that you have. We can also offer you additional support at home. So there can be nursing that's covered by insurance. Some states now have family caregiver support that is paid for, meaning that it can't be a parent, but it can be an aunt, a grandparent, a family friend who can be the primary caretaker for your child and actually get paid for that by the insurance. Some states also have rehab facilities that can help as we transition home as a step towards home. We want to make sure that we're also managing your stress. Your well-being matters. If you can't take care of yourself, if you're not resting, how can you take care of your child or your loved one? We need to provide you with comprehensive education, and practice is really key to this. So make sure that we're giving you materials, that we're giving you hands-on training, and you can request and you are encouraged to do a 24 or 48-hour room-in before you go home. So that means spending 24 hours in the hospital, doing all of the care for your child or for yourself. And this is very advantageous because you have the nurse, you have the medical team there to back you up if you have questions. And then when you go home, it won't be the first time that you're connecting tube feeds. It won't be the first time that you're connecting TPN. Managing medications and supplies. We know that a lot of things need insurance authorization. Every insurance is different. Every week, different things are covered and not covered. So make sure that you are going home with everything, that we don't have a surprise when we're discharged, that suddenly you don't have ostomy bags or you don't have an important medication that you need. Coordinating with home healthcare agencies and outpatient providers, and making sure that your appointments are scheduled for you. When you get home, maintain a schedule, stick to a consistent family routine. We know there are a lot of things that are outside of our control, so we want to be able to control as much as we can and offer our children choices whenever we can, even if it's something small. Just offer them a choice to give them that sense that they can control something in life. Find a space at home that's going to be calm, comfortable, and clean where you're doing the TPN. If you're doing tube feeds, you don't want to isolate the child and have them be on the side somewhere. Even if they're not able to eat with you, sit at the dinner table, have the child get their feeding tube feeds while you're at the table having dinner. Just involve them as much as possible. And this is an example of a discharge checklist that we can use. And again, it has to be individualized for your needs, but make sure that the care plan is reviewed. Make sure you have your medications, know what they are for. Make sure you have all of your supplies. Know what potential warning signs and problems are. When do you need to call? When do you need to come back to the hospital? Who do you contact? Make sure you have all the numbers. And we often give you this in a big stack of papers that can be lost. Put the numbers into your cell phone. Take a photo of any material that we are giving you. So making sure that you know who your doctor is, who your home care company is, where you're getting your TPN from, where you're getting your formula from, who your pharmacy is. And sometimes there might be many different pharmacies and companies that we have to work with because insurance doesn't always cover everything that we want to. We have to use different companies. Make sure the follow-up appointments are scheduled before you leave the hospital. I've seen this too often where patients are discharged and they get a list of 10 phone numbers to call to schedule an appointment with gastroenterology, with neurology, with a NICU follow-up clinic. That's not fair to you. We have people in the hospital that can make those appointments and try to coordinate them so that you're not coming back to the hospital now every day. Coordinate whatever we can. Make sure that we're providing you with education and resources. Know the size of the central line, know the size of the feeding tube, know what the formula is, make sure that you're mixing it correctly. And we can also provide you with an emergency room letter that describes your child's condition in case you need to go to a local hospital and not back to your main center. That has information on what to do in case of an emergency. So if your child has a central line, has a fever, the hospital needs to know not to discharge you home, that they need to admit you or transfer you somewhere else and notify your medical team. So now we've been home, we've managed that, everything is going well, and now time comes for entering school. So how do we make that transition? There are many challenges involved in this. So there's emotional and social challenges. So we now have to adjust to new routines, new environments. There's separation anxiety, and this is the children having separation anxiety as well as the parents. Fear and difficulty forming new relationships. There can be challenges collaborating with the teachers in the school, communicating the special needs that the child might have. There can be challenges with individualized support. So some children may need additional support or accommodations at school. They might need to receive medications, feeds, TPN, or be on a specialized oral diet at school. And we need to balance this. We need to provide them with appropriate services at school, make sure that we're meeting their needs, but also make sure that they're being included amongst their peers. We don't want the child to go to school and sit at the nurse's office all day. We want them to be involved with their peers and do as many activities with their peers as they can. What happens when we miss school? So this can be planned due to appointments, procedures, or it could be emergency procedures, emergency hospitalizations, or illnesses. So what can we do to overcome these challenges? First of all, we want to provide a supportive and inclusive school environment. You can have the child visit the school before they start so that the first day of school is not so overwhelming, that they've already been to that new setting, that they've already met some of the teachers, and promote social interactions and peer connections. We can collaborate together with the school by having school readiness resources. And this is an example of a school readiness package that Stick Kids in Toronto put together. So it gives you some handouts that you can share with the school so that you can explain what the child's central line is, that they have a feeding tube. And they also have some videos that can be shared with the classmates where the child can explain what short bowel syndrome is, why they carry a backpack, and make it less intimidating by having the child have to say this themselves. You can share some of these videos, and they're available on YouTube. Providing individualized support. So we can help you fill out the paperwork for this, but there's IEPs or individualized education plans or 504 plans that can provide extra accommodations at school. And we can have a nurse or a para at school accompanying the child to help them out. For missed school, so we can plan ahead as much as we can, communicate with the school, request assignments. When the child is admitted to the hospital, there's often teachers that can provide hospital-based education. You can ask the school if there's remote learning options. And if the child is going to be in the hospital for a while, we don't want them isolated from their peers. So maybe they can do a FaceTime, maybe the kids from the class can come to visit them. And now one of my favorite transitions as we move from being a child to an adolescent. And we all know that adolescents can be very moody. They don't often listen to what we tell them to do. And this is really a process that has to start early before they, completely close off their ears and don't listen to anything that we say. So there are challenges associated with this: physical, emotional, and mental health challenges. Oftentimes, children with short bowel syndrome are going to be different from their peers. They might have growth delays, they might be shorter, they might have body image concerns of having a central line, having a feeding tube. In general, in adolescence, there's heightened stress, anxiety, and depression, and we see this more so in kids that have a chronic illness. There are going to be challenges with having peer relationships, feeling isolated, struggling with disclosing their condition. A lot of times, children don't want to wear the backpack, they don't want to tell other kids what they have. And there are going to be challenges in social situations. So not being able to eat the pizza with your friends, not being able to go on trips because they need to be home to get their TPN. There are going to be challenges with that. Academic challenges, so missing school, managing the workload, and thinking what happens after high school. There are struggles with independence, so adhering to treatment plans. My well-behaved younger patients, as soon as they become adolescents, stop taking their medications, will disconnect their feeds, and they often don't make responsible choices in general in adolescence, and especially not related to their condition. So what can we do to help them thrive through this transition? So this is on us as clinicians to provide mental health screenings. If we don't ask if they're depressed, if they're having anxiety, we'll never know. And most often the adolescents will not just disclose that to us. We have to provide them with therapies and support. Mental health is lacking in this country. I strongly believe that everybody should have a therapist. Everybody has challenges. Everybody has things that they need to discuss. We don't always have that available, and especially for children, especially for children with a chronic illness. But there might be a social worker that works with your team that can provide them with some of that counseling and support. And we're trying to incorporate psychologists more and more into our GI clinics that are familiar with chronic GI disorders and at least can provide you with short-term counseling and support and make the referrals for long-term therapy. We want to make sure that the adolescent has somebody that they can talk to, whether that's a peer, a friend, a teacher, or somebody from our team. With academic challenges, we want to individualize, again, academic support and accommodations, provide career counseling. Not every adolescent will have the same abilities. If there might be adolescents that have some neurocognitive delays, but we can still foster their ability to be independent and come up with plans after high school. We want to encourage the child to participate in their healthcare decision-making early on. We want to provide education and support them, making sure that they understand what their condition is, if they understand why they need to take their medications and what the consequences are if they don't. That might help with adherence and helping them with self-management. And encouraging one-on-one time with the medical team. There might be things that they are not comfortable talking to their parents about. So having that one-on-one time with us where they can understand that most of what they tell us is confidential and they can ask us any questions that they have. And this is an overview of the transition process, and we divide it into 3 stages. So in early transition, the parent is the manager of the healthcare tasks. And as we moved towards middle transition, the parent shifts to becoming the supervisor of the healthcare tasks. And as we reach later adolescence and young adulthood, the parent will now serve as a consultant for their child. And early in transition, we want the child to begin to participate. We don't expect them to be able to do everything on their own, but you would be surprised how many kids I see in clinic that don't know what they have. They come to all the appointments, they're there, but they're often on their phones, they have their AirPods in, they're not listening to us. So talking to them early on, explaining what the condition is, and getting them involved, getting them to ask any questions that they have. And then moving on to middle transition, we want the child to now start managing their condition, but they still have supervision from their parents, from the medical team. So have them start taking medications, see if they can start doing that one-on-one time with the providers, if they can send messages to the providers through the portal, refill some of their prescriptions. And as they get older into the later part of transition, really have them do the whole visit on their own. You don't need to be there for the whole thing. You can come in, ask a couple of questions, and then have them spend most of the visit together with the provider and the team, and have them refill their prescriptions, help them out as they're looking for adult providers, but really just increasing their independence. And now we reach the transition from being an adolescent young adult to being an adult and having to transition from pediatric care to adult care. Unfortunately, we don't have a magic adulting potion. If somebody invents that, they will be a billionaire, but we don't have that. So all we can do is provide them with tools to make this more successful. And I'm just going to start off with some definitions. So there's a difference between healthcare transition and healthcare transfer. Healthcare transition is a process, and this is a change from a pediatric to an adult model of healthcare. It's a gradual process that involves many steps, and it starts early on in adolescence and continues through young adulthood. And this process addresses the medical, psychosocial, and educational needs of adolescents and young adults. The transfer process is a single point in time at which the responsibility for providing care moves from a pediatric to an adult provider. And this is something that we have to do. So as pediatric gastroenterologists or pediatric surgeons, pediatric dietitians, we unfortunately are not equipped to handle a lot of the things that come up in adulthood. So at some point, we do have to transfer care. And our goal is to optimize health and assist the adolescents and young adults in reaching their full potentials, making sure that we're providing continuity of care and avoiding complications that are preventable. Not everything is avoidable, but there are some things that we know that we can prevent. What are the challenges? So there are challenges from every stakeholder here. There are challenges from the adolescents and the young adults. They're often not adequately prepared. They don't know all of the intricacies of taking care of their condition, and they often struggle with independence. And that is a struggle for every adolescent, and it's just compounded more when you have a chronic illness. Parents often struggle to relinquish control. As I said before, nobody knows your child better than you do. And there's a fear that when we transfer and transition from the pediatric to the adult world of care, that you might not be listened to. The adult care is a little bit more austere. It's less of the teddy bear environment that we have in pediatrics, and you might not be included in some of the discussions. As pediatric providers, we also struggle to relinquish control. I am very attached to my patients, and shout out to Sarah and her mom, who I hope are there. They were able to make it from New York. But we get very attached. We watch these kids grow up. We put a lot of effort into having you succeed. And it's very difficult to suddenly trust somebody else with all of that care. And we often fail to assess for transition readiness. Adult providers have challenges. One of the biggest ones is that we don't have enough adult providers who specialize in short bowel syndrome. We don't have multidisciplinary teams set up in the adult world in the same way as we do in pediatrics. And the adult providers might not have the comfort, skills, or desire to care for these complex patients. And then there's systemic challenges. So again, that lack of the multidisciplinary teams on both sides. So you need a team for this transition process. It's not something that one person can do alone. And there's lack of communication and coordination with the transfer process. What often ends up happening is you have a 23-year-old patient, there's a complication, they get admitted to the adult side because that hospital has a cutoff. If you're 23, you can't go to pediatrics anymore. So now you go to the adult emergency room, you get admitted for a few days, and now people say, okay, well, you already went to the adult world, let's just keep you there. That is not how this works. We need to start this process early. And again, it's a process. We can't just say you're 22, you're 23, go to the adult world, good luck to you. That doesn't work. We have to start this early. And most experts recommend starting this process around age 12. And I'm going to be using another mnemonic here. This one's going to stand for transition. We have to be resourceful. We don't have to reinvent the wheel. This is transition right now is a very hot topic in all areas of chronic illness in pediatrics. There are a lot of resources available, and I want to just reference a paper that I wrote with Dave Mercer that was published in JPEN a few months ago. And this website Got Transition, which has a ton of resources that can be customized for any chronic illness, that gives you transition readiness resources, gives you information to give your team, to give your adolescent. We want to be all encompassing. We don't want to transfer just the medical side of it. We want people to transition that therapeutic relationship that we've established. We want to make sure that we're transitioning all of your care. So if your child has other comorbidities, if they see a neurologist, a hematologist, we want to make sure that they have those adult providers set up as well. And we often work together with other subspecialists and make a decision together of when we are actually going to make the transfer of care so that you're not having some providers on the adult side and some still in pediatrics. We want this to be a navigated process. Somebody has to run the ship. And that can be your main provider. Often it's somebody in the clinic, like a nurse practitioner or a care coordinator that helps you throughout this process. This needs to be structured. We need to have steps. And GOT transition gives us 6 core elements that your team should follow. The first is establishing a transition policy. When will the actual transfer of care occur? And every hospital has different rules with this. We want to know kind of early on what to expect. We want to make sure that we have a list of checks and balances, that we're preparing for the transition, that we're assessing readiness, and that when the actual transition comes, that we have everything set up with a medical summary, and that the adolescent is fully prepared for the adult approach to care and is independent. And one other important thing to mention here is we want to make sure that the actual transfer occurs during a time of stability. So we might prep you to transfer in September of next year, everything is set in place, but then you got admitted with a Lyme infection or you had to go back on TPN. That is not the time to transfer to a new center and a new provider. So we have to make sure that things are calm and collected before we make the actual transfer. And then once we transfer to adult care, the process doesn't end there. We as pediatric providers have to make sure that the transfer process was successful, that everything went as planned, that you're going to the adult provider, that you're happy with that adult provider. And we can still offer pediatric consultation. And sometimes we can also do like a joint visit with the adult and pediatric team together. We want to make sure this process is interdisciplinary. So I mentioned before the interdisciplinary or multidisciplinary team. And this is important when we care for short bowel syndrome. And it's also important for the transition process that we work together with the surgeons. We work together with nurses, nurse practitioners, with you as caregivers, with your child, with the home health care team. Everybody that is involved in your child's care needs to be part of this transition process. We need to teach you. We need to provide you education about what your disease is. How do you control it? How do you manage medications? How do you manage daily tasks? How do you appropriately utilize the healthcare system? So if you don't feel well, what do you do as an adult? Do you just show up to the emergency room? Do you send a message in the portal to your provider? Do you call? How does that look like? And then we also want to make sure that you're living a physically and mentally healthy lifestyle with exercise, nutrition, talking about reproductive health and mental health, talking about travel, talking about quality of life. This process has to be individualized. We know that everybody has different needs. Everybody will learn things differently. So it's not a one size fits all. We have to be open to suggestions. We want to hear back from you. This is definitely not a process that a lot of us have gone through. And this transition of care to adulthood in short bowel syndrome, I often say, is a very good problem that we have. It means that we're doing a good job. It means that our kids are surviving. And we want to hear from you how we can make things better along the way. And we want to be nurturing. We want to support the child as they're going through this process, but we also have to make sure that nurturing does not equal enabling or coddling them into adulthood. We have to give them some independence and have them slowly go through this process. And then I'm going to touch about some transitions that occur throughout intestinal rehabilitation. So these might be transitions as we're going on PN, going off PN, on tube feeds, off tube feeds. As many of you know, we can't just stop TPN. We have to wean it slowly. There are unique challenges in adjusting the dietary regimen to make up for the calories from the PN or the tube feeds, balancing oral intake with output. It can't just be we're telling you to stop PN, good luck to you, eat food. That doesn't work. We have to follow up with you. There are challenges when you have surgeries. So some of these surgeries might be planned. Sometimes it might be another resection. It might be a line placement. It might be transplant. So we have to think of the challenges that involve that whole process with perioperative planning and the emotional and psychological toll of yet another surgery. So what can we do? That multidisciplinary team, again, really key in every step of transition. For nutrition challenges, we want to set clear goals and timelines. Wean things off gradually. Make sure that you're tolerating it. Have closer follow-up if we're in the weaning process. Making sure that your nutritional status is optimized, making sure that we're checking your vitamins, making sure that you're gaining weight or that your weight is stable. Providing you education on the oral diet. How do we manage complications? And what do we do if there's setbacks? There are going to be setbacks. That's part of life. So how do we manage those? Challenges with surgery. So we want to have close collaboration with our medical and surgical teams to ensure that we're coordinating care. Talking about the surgery ahead of time, making sure that we're having pre-op planning, establishing our post-op plans, including what to do if there's pain, how long will you be in the hospital, and then something that I think we often take for granted is the importance of child life involvement. the importance of art therapy, music therapy, support dogs. We often take for granted how traumatizing some of these experiences can be. For us as clinicians, I'm doing an endoscopy. I do endoscopies every week. When my patient comes in and now they're coming into an operating room and they're terrified that they're going to have a surgery, and I have to explain to them, this is just an endoscopy. This is a routine procedure. You don't have to worry, but they're terrified. So recognizing that medical trauma is part of this and addressing that and preparing them and trying to minimize any more damage emotionally and psychologically. And then the last transition I'm going to talk about is one that Beth mentioned earlier, and this is a transition to end of life. This is a talk that we don't want to really focus on. I can tell you as a pediatrician, we don't get a lot of training in this. We hope that everybody goes through this transition when we're all old and gray, but this is a reality of life, and if we can't just ignore it, we have to talk about it. And it has its own challenges. There are, again, physical and emotional challenges, so there might be pain or discomfort as there's declining physical function. There might be fear, anxiety, denial that it's the end. And as caregivers, there's going to be burnout, emotional distress, and financial strain. How do we make decisions about end of life? We want to involve the patient as much as we can. We want to balance the desire for quality of life with potential harm that we might be doing with more medical interventions. How can we support through bereavement process of grief, loss, and financial hardships? We can provide you with support. We can provide palliative care. A lot of times in the hospitals, there will be a palliative care team that is more trained in this and can provide you with support and think of ways to improve quality of life. We can provide emotional, psychological, spiritual support through counseling, therapy, and support groups. And we want to provide opportunities for patients to express their wishes and their desires, and opportunities for the caregivers to have some respite care. We know this is a very tough process to go through. Having open and honest conversations is important. We want to know what the patient wants, and again, making sure that the decisions are being shared by the patients, their loved ones, and the healthcare team. There's support that we can offer throughout the bereavement process. Again, this might be counseling, it might be support groups, but it might just be reasonable, practical resources that you might need for funeral planning or legal matters. And that's something that our social workers can assist with. So to summarize what we've talked about, we've watched Gutsy grow up and survive and succeed and thrive. And I'm actually going to summarize the key takeaways from the initial question that Maisie asked yesterday. And she asked, what do you want to learn at this conference? So I copied some of those terms and made it into another word cloud. And I think this really summarizes everything beautifully, with community really being at the forefront of all of this, having education, having knowledge, inspiration, and hope. These are some references. I want to thank my pediatric intestinal rehab team at Columbia that works with me to take such great care of all of our kids and our young adults. And I'm going to end this with one more acronym, so GUTSY. GUTSY stands for Gradual Transitions. U, understanding the needs at each phase of transition. T for tailored treatment plans and team coordination. S for support networks. Y for yielding positive long-term outcomes. And the D at the end is for getting a dog, because dogs just make everything so much better. Thank you so much, and I'd love to open it up for any questions that you might have.
First of all, thank you so much, Dr. Kinberg. It's interesting to sit there and listen to you talk about this, and I just love your humanity. Like, I didn't know where you're going with that life thing, because I'm like, what the heck? That doesn't sound like her. She's out of touch. So what a way to do that. That was amazing. I appreciate it. And I know to some of the audience members, not everybody here is short bowel syndrome. I get that, right? So what I find is that almost everything that she said was applicable across all of nutrition support. Like, my own son doesn't have short bowel syndrome, and yet almost every single thing that she said transitions to all those things. And so thank you so much, Dr. Kinberg, for bringing this topic up. I think it's the beginning of the conversation. This is nowhere near the end. This is the beginning of the conversation, and I'm so thankful. What I want to share is a little experience. I don't know how much you can see of this, Dr. Kinberg, over here. So at this side table over here is Sarah. Sarah is one of her patients, and she's waving at you, and she was waving at you through the whole, that's my doctor. she kept saying, "That's my doctor, that's my doctor," and her twin sisters over here waving because they're all part of the family. That's part of it is we often, clinicians often think of the patient and don't realize that you're treating the whole family, right? You come to know the mom and the dad and the kids and the siblings and all that. So thank you so much, Dr. Kinberg, for being somebody who represents the whole family. So a real quick story is, she says thank you. I don't know if you can hear her. So she is one that, so Dr. Kinberg did a little snippet of a speech for me at Aspen, and at the end she had this video, and it was of Sarah, right? And it was, the doorbell rang, they run to the door, and she sees that it's her supplies, and she starts yelling, "It's my medicine, it's my medicine." It's the cutest video ever. I need to like loop that on if you ever need a joy infusion, right? Because that's not necessarily the way that it is presented to us. So a 5-year-old who is saying, "Thank you for my medicine," that's part of life too. So thank you so much again for doing that. I actually have a question for you, Dr. Kinberg, because it's a little hard to get to some of the audience here, but what is the one thing that you have learned from patients that you would love to share with other clinicians and families? How have you personally been changed as a doctor by going so deep into this world?
That is a very good question. And I think a lot of times we focus on the challenges and we're focusing on the medical side of it. And there's several of my families have my cell phone number. And I've told them that if you're going to message me when you have a fever, when your central line breaks, I also need cute pictures. I want first grade graduation pictures, first day of school pictures, and having that connection with the families. And that really shows how rewarding this all is, and just learning from parents. And one of my favorite conferences is the Oley conference. And I'm so sorry that I wasn't able to be there in person, because I learned so much from all of you. And I take the lessons that you teach me and I share them with other families. So I get the biggest takeaway in all of this discussion is talking to each other, making sure that your voices are heard. We do want to hear them.
Well, thank you. You're one of those, not everybody gets it, and you're one of the ones who gets that. So I'd say to all of you too, if you have doctors and clinicians and dietitians and so forth that truly get you, they're keepers. I don't know about you, but I call myself collecting people, right? So those who I feel I'm the quarterback of our team. Or maybe the coach of our team, maybe a better analogy, right? And so if we can all play nicely together and we can coordinate, because like I have an IR doctor here, right? I don't know, I didn't go to school for an IR doctor, but he knows things I don't know, but I also have some stuff that he doesn't know unless we talk. And I have a dietitian that they can't know if we don't talk. And so to me, coordinating the team, it's also exhausting to be the coordinator of a team, and we need all the support we can get. So my suggestion is everybody, if you don't have a really good team, start to build that. Some are like rehabilitation centers or they're centers of excellence, and you've got that all together, but most of us don't. Most of us, about 90%, we find out that don't. And so I don't know about you, but I've had to collect my own. Do you have one piece of advice about how we can go from there? Like if we're not near a center and that's not an option for us, what's the one last piece of advice you can give us about how to build our team? Because you've built a good one.
Yeah, and that is tough if you're at a place that doesn't have all of these team members. And remembering that you're part of that team, and the home health agencies have nurses and they have pharmacists that can help provide you with some of that support. Sometimes they're not very hands-on, but they can be, and you can reach out to them. So if you're getting feeding supplies, if you're getting parental nutrition, there are team members there that can help you. And then reaching out to centers. I mean, there's so much that we can do virtually now, coming to these conferences, having your own support network, and having the team, if it's not going to be medical professionals, have the team be each other.
Awesome. Well, thank you so much. Can we give another hand for Dr. Kinberg?
Thank you so much. And as Beth said, this is just the beginning of the discussion.
Thank you for being here. And next year we'll try not to have tornadoes and problems to keep you away. How's that? I'll work on that.
If you can control that.
I'll work on that.
Or have the conference in New York, where I live.
Thank you so much. So we're going to transition now, and it's a nice little transition here because we're going to be talking about an empowered healthcare experience the importance of mental health support in optimizing medical outcomes. And I can't think of anybody better to do this than somebody who has studied this, is helping other people through this, but also has the lived experience. And so I will let her do her own introduction on who she is, because that's part of her beautiful story. Would you please join me in welcoming Oley Becker. Thank you so much. And there's a clicker right here for you.
Okay. Well, thank you so much. Can you guys all hear me okay? Awesome. Thank you so much for that introduction. Throughout my presentation, you're going to learn more about me, because that is a part of my approach. I'm not going to tell you too much right now, other than I love that I'm following the speech that I did, because my rather traumatic experience through transition from peds to adult is what led me to want to become a therapist myself. And I love that we're talking more about that. And I love that she talked about everyone being able to benefit from therapy. I like to tell my own clients that the best therapists are the ones that get therapy themselves, and I firmly believe that. So I don't have any financial disclosures. My objectives today, a little bit, I do want you to understand the potential use of therapy and the therapeutic relationship, because I believe that's where the power of therapy really is, with some accessing of care. I'm going to kind of talk more about how it relates to chronic disease management, and do that by focusing on common themes that come up. And that includes personal identity, self-efficacy, grief, and body image. And really what I want to do here is have everyone leave with a practical understanding of what therapy looks like, as if you were a fly on the wall in the room. I think a lot of us often hear about how mental health is affected by chronic disease, and we often are told, go get therapy or find that support. But we aren't given practical information of why that would help and what that help looks like. So I've made a really deliberate focus to look at that and less on the research side. So to that aim, just a brief introduction of what exactly therapy or counseling is. This picture, I think, is what most people kind of think it looks like, right? One person's kind of leading the session, one person's kind of like, woe is me, and kind of talking about things, not facing each other, and I really want to challenge that. So it's professional and collaborative, and the professional side is important, that training that we get, and it includes professional counselors like myself, psychologists, marriage and family therapists, and social workers. All have a master's level or doctorate and clinical internships, so there's a lot of training that goes into it. But unlike other professional relationships, we really focus on the collaborative side. We are talk or dialogue based. It's our medicine, so to speak, or if you're a painter and you paint, for us it's talking and dialogue. It's that back and forth. We always value education and the idea that you can improve yourself always. There's no like you get to this point where you're an expert and understand. And that's really why it's for everyone and you can always benefit. We're wellness-based, so looking at the bio, the psycho, the social, and the spiritual, I think people think they're gonna come in and we're only gonna talk about emotions. We do talk about those things, but that's a very small part of what we do. We look at reducing distress related to experiences, thoughts, and emotions. We realize we can't stop bad things from happening. We can't stop difficult emotions from occurring. So instead, we focus on reducing that distress and then hopefully giving you tools to make that happen less frequently. And again, proactive and preventative. So we want to definitely see you if you're in a crisis, for sure. We also want to see you when you're doing really, really well and give you tools to be able to get through those difficult times. So I'm going to challenge that and say this is much more what it should look like. The couch is still there. If you want to lay down, you can. But really facing each other. You're going to see there's conversation bubbles above both of their heads. It's a give and a take. And while we might write down some information or try to help you with referrals, most of the time we're not writing, most of the time we're interacting with you. So how does this kind of intertwine with chronic illness? Well, in order to kind of show this, I decided to focus on 4 themes, which is a lot of themes for a 45-minute talk. So I'm going to be moving really quickly. And so if your experience with these themes is different than I discussed, that's absolutely normal, okay, and true. So I'm only scratching the surface. And in thinking about how to do this, I'm going to talk about my own personal experience as I talk about these themes. So again, my experience is one experience, and so don't think that if the interventions I talk about today don't seem like they'd be helpful for you, that therapy isn't helpful overall. So I want to start with personal identity as a theme, because this is something that therapy focuses on directly all of the time. And it's this question of who are you? Who am I? And what does this look like for me? So this is a really good way to think about personal identity and what healthy identity looks like. There's a bunch of concepts that kind of come together to form who you are. This includes things like personality traits. Are you introverted or extroverted? Your interests and your dislikes and how those things affect the choices you make on a day-to-day basis. Your social identities, race and culture, and having a chronic illness. Your career, your profession, your values, your family roles. All of these things really come together to identify who you are as a person. And so when we think about this in mental health, what is a healthy identity, right? We're all very unique and there's lots of things that come together. Really what we want to think about is we want this to be balanced and we want it to be consistent. So we want your ideal identity, how you perceive yourself, to be expressed in the way that you're living your life. So we want it to be stable, not in that we never evolve and change. Education and always changing is a part of life. But if your identity is changing on a day-to-day, week-to-week, month-to-month basis, that instability is really difficult to deal with. So we want it to be balanced and we want it to be generally moving in a stable direction. And I think really the cornerstone of it all is that any disconnect between a person's desired sense of identity and their actual lived experience is going to cause some mental health struggles. So when we think about this in the perspective of chronic illness, many times you probably have heard the word illness identity. And I think sometimes it's used in ways that's difficult to understand or that can make the patient or the person who's kind of discussing this feel like how they view their illness could be wrong or maybe detrimental. And so I want to look a little more at this because really all it is referring to the degree of which you integrate your illness into your identity and the way you view your illness as a part of your identity. So limited integration, meaning if you try to deny that your illness exists and put it in a corner and try to live your life without anyone knowing it, you're likely maybe to not do all of your cares to the way that maybe would be the most healthy. You're kind of living a mask and you're walking around like a different person, and that's really exhausting, even on the best of days. And so that's a difficult place to live. That's a difficult place to kind of go through life. But if your illness is all you have in your life or your prominent identity all of the time, it's going to be difficult to maybe approach goals in the same way. Symptoms might be harder to manage. And I think it's important to say that that doesn't mean that your symptoms are worse because of you. That is not at all what's happening. But if your illness is constantly on your mind, it is more difficult to find other ways to cope with those symptoms. So therapy kind of comes in and tries to find balance with this and tries to put identity back together by incorporating the illness instead of separating it off or making it the total part of who you are. We recognize that it's present in all themes, so this is why I'm starting with this, because it's going to show up in everything else I talk about today. And really, we're looking at developing your strengths and your interest in the resources that you have so that you can integrate that illness, because illness does change some of your strengths and your abilities. And so we have to adjust for that. And counseling takes the point of view of we're going to find the things you're really good at, and we're going to find a way to make that supplement the things that are really difficult about your illness. So I'm going to talk to you today about my identity integration. I'm not going deep, I'm going very quickly. So if it sounds like I mastered this overnight or I got here really easily, that is not the case, and it's something I'm still really working on. So you can see in the picture all the way over where I'm a little toddler. I'm a teacher's kid. So I'm in my mom's classroom at that time as a toddler, pretending to teach the class. And I'm talking about my interests and values and personality in this section. And you might already see that what I'm doing right now is pretty in line with what I was doing as a toddler or pretending to do. So I think this is a good example of my interest in the skills that I naturally have, taking the lead or being a little bossy, being empathic, wearing my emotions on my sleeve, but therefore being able to see that emotion in others, and verbal and reading skills. Do not ask me to do any math, and how this is kind of connecting. And then I had my patient identity, and this is never going to go away, right? So it's important that we recognize it and we don't throw it away. For me, this includes diagnoses like EGPA, it's a vasculitis condition that's rare, mast cell activation, and a bunch of secondary diagnoses underneath that led to some intestinal failure, and the interventions that help me deal with these things, along with the symptoms that they're treating. So for me, that includes severe lung disease and having to be on TPN. My slide says 11 years. I realized the other night that it's 12 years of TPN, and I had enteral nutrition before that. And so all of those interventions come together to form that identity, and it's not just the physical experience, but the way my life has to change to make those interventions possible can all kind of fit into that bubble. And then we have the patient advocate side. And for me, this really developed in a time of a lot of distress. I was in the hospital for hundreds of days at a time, getting out for a few weeks and having to go back in. I was having to drop out of college, which for me, being academic-minded, was like what gave me purpose. And I was really struggling, and my patient identity was really the only identity I had. And my palliative care doctor, who is pictured there under that patient advocate picture, recognized this, and she said, okay, we gotta do something about this. And we started really small. She said, will you come, I know you're admitted, will you come talk to a few med students in the hospital in between your infusions and just tell them about your experience, right? So that's where we started. And from doing things like that, I realized, oh my gosh, I can find a way to make this meaningful for me, and that's in line with my interests, because I like to do these things in general. If you're someone that doesn't like to talk to people, then this might not be how to integrate your illness, but I promise you there's ways to do that. And so for me, this really grew, and the picture there, I'm standing with who was at the time Governor Branstad of Iowa, and we had helped to facilitate a Palliative Care Act in the state of Iowa. So being able to do really cool things like that, in addition to things like speaking here. And that really made me feel like my illness was important. But I was still missing this idea of normative impact in the world, or the career side. And that's when kind of wanting to become a therapist, and through my own experiences, took me there. Again, it's in line. I like to talk about emotions. I am an emotional person. I've been blessed with a lot of support in my life, and so I can help to facilitate that in others. And for me, it made a lot of sense. And that's when I got to this meaning-making purpose. And that's really what we're looking for. Incorporating your illness, your strengths, your resources, and helping you to make meaning out of that experience. And therapists are really good at helping you find that and navigate that area. So again, I'm doing quick transitions because of time, but I wanted to talk now about self-efficacy, and you're gonna see identity come back in this area. And this especially comes up in disease management. Self-efficacy refers to an individual's belief in his or her ability to succeed in achieving a goal, and kind of the confidence that the person has. Do they feel like their motivations can become reality? Do they feel like they can control their behavior or their environment in any way? And importantly, because some of you might be going, well, that sounds great, but there's a lot you can't control with an illness, right? So what exactly does that mean? You can't control these things. Well, I think what's really important to understand is that self-efficacy doesn't mean that you're doing everything yourself, but it means that you feel like you can control your direction enough to be an active player in your care and to seek support when you need it. And so that can look like, getting new skills to be able to access your own port, or learning new tools to succeed, or being willing to go to another person and say, I need additional support. In some of my examples, you've seen some of this come through, but self-efficacy is really closely tied to adhering to routines, to participating in appointments, feeling comfortable speaking up and saying, I can't be on TPN 22 hours a day. That's not gonna work with everything else I'm doing. We have to regroup here. And feeling confident to be able to say that out loud in the room comes from feeling like you have some sort of control over your experience. And we experience a lot of things through chronic illness where we feel like the control is taken away. And so getting some extra support and learning to take that control back is really, really helpful. And if you're a provider, helping to facilitate that belief that you can have some sort of control in the people that you treat or interact with is really important. So what exactly does this look like in reality? And this is where my story comes into play. So these are my daily IV medications and bags that I'm managing. And it's a lot. And I have to manage these things even when this is my internal experience, right? If you are not someone who's on these treatments or a provider, or you work with supplies, if you've ever come home late at night from a meeting or a party and thought to yourself, I can sleep in my clothes just this one night, it won't matter if I don't brush my teeth this one night, you have a little taste of what it really feels like to be in this position and how your sense of control can slip away. It also comes up a lot in healthcare decision-making. This is a favorite meme of mine, trying to keep all my conditions in check. So for me, the one on the left is pulmonary and my lung disease. The one in the middle always coming at me is nutrition support. The pesky little guy in the corner, that's infectious disease, always there to kind of pounce at the worst times, right? And so I'm constantly like fending everything off, and that's exhausting. That's a lot to take on. And so it's really easy to kind of have that sense of control, like anything I do can make a difference when that's my day-to-day experience. And when we're talking about decision-making in healthcare, this is often how patient-centered care kind of occurs. I know it's not the goal, right? But it's this idea of the patient being pulled all directions. I'm going to give you a little example from a recent line infection. Going into the hospital and having infectious disease come in, we got to take that line out. You know that line being in there can kill you. It's got to come out right now. About 2 minutes later, GI walked in. Do not take that line out. We're going to treat that with antibiotics. You're losing access. It's got to stay in. Okay? Then comes in the hospitals. Oh, you've been on TPN for 12 years? We got to stop that right away. You can't go home on TPN. I mean, okay. And then in comes pulmonary or vascular. We can't take you off those medications. I know they increase infection risk, but have you seen your progression? Okay. So they all walk out, right? And then everyone kind of looks at the patient like, what are we doing here, right? And so, you know, self-efficacy looks like saying, hey, Oley, come back. I'm not making this decision on my own, right? Talk to each other. And that's hard to do in a hospital system when they're going to fight it. We don't do that here. We don't have time for these meetings. These people aren't in the building. And so sometimes self-efficacy looks like really helping to make that communication come together. Okay, so that sounds great, but how does therapy actually help that, right? Well, it helps you learn to break goals into manageable parts. And I love this graphic because the two people on the ladders they have the same abilities, the same starting point, the same desire to succeed, the same end point, but they're in very different situations. The one guy has to really challenge himself to get to that first rung. The other guy's just kind of walking up and down. And so we take the view of not addressing problems from, hey, this is my end goal, let's get there, but instead saying, where are we right now? How do we make that one incremental step forward? So what does this look like? Something like a ladder scale, which I love to use in sessions with my clients. Come in and say, let's say someone comes in and says, I really want to get off this medication. It's helping a lot of my symptoms, but it's causing a lot of side effects, and I need to get off of it, right? And I'll ask them, well, where do you think on a scale of 1 to 10 you fall on this? And a lot of times they'll say 0, 1, I'm on the medication. And through some questioning, I'll get them to realize you're not at 0. If you're thinking about life off this medication, if you're picturing challenges and you're trying to gear yourself up to be successful, you're doing work and you've made progress. Your level of change is moving. And so maybe we come to the realization we're more at like a 2 or a 3. My next question to them is going to be, what do you think a 4 looks like? Because I don't know what they think their 4 looks like or what their understanding of meeting their goal looks like. And if we're starting off on different paths from that perspective, we're not working collaboratively together. And then I'm going to say, okay, well, how do you think you get from 3 to 4? And then we're going to really just focus all our efforts on that and take it rung by rung. Because every time you get that number up, you increase your confidence and the ability you have in yourself. and it makes it that much easier to make more changes in the future. It also looks like having help making sense of what's in your mind. So I love this picture because a big thing in therapy is we do not give answers. We don't advice give. We firmly believe you're the expert and your lived experience is what matters most, and you have the answers inside of you. They're usually just jumbled up because so much is happening and so much pressure is on you. So therapy is a lot of just trying to help you and assist you in making sense of what you know. And so this can look like role playing, pretending to be a physician in an appointment and having someone talk through what they want to tell their doctor. And that way, the first time they're talking about these to someone else in kind of maybe a little bit of an adversarial position, hopefully not, but sometimes that is the case, isn't when it's really happening. And you can make new connections. Or we can do mind mapping tips. Maybe the goals most important to you are reducing pain and going to summer camp. And it's hard to see how those are connected together. Well, we might do an activity where I say, for 2 minutes, you're gonna write down everything that comes to mind about your pain. It doesn't have to seem to make sense, it doesn't have to be connected, and we'll do that. And at the end of the 2 minutes, we set it aside and we do the same for camp. Are there similarities in these? Are there things that are on one list but not the other? And that can help you to see new connections that maybe weren't as obvious before. Now we're to some of the more tough ones, and that's grief, but it's one that I think is really important with chronic illness that we talk about. First, grief is a natural response to loss and a universal experience. Whether you're born in North America, South America, Europe, Antarctica, you're going to experience grief, and no matter what culture you are a part of. It's a normal part of life, no matter what other things are happening, whether you have a chronic illness or not. It's described as a deep sorrow, as the emotional suffering experienced when something or someone that you love is taken away. It cannot be ignored. You can push it down for a while, you can black it off for a little bit, but it's going to come back. Really, the only way through is to go through that. It's sneaky and it has a time component. Even with the best therapy in the world, right? It's going to take time and it's never gonna fully go away, but it's about learning how to cope with that grief and find value in grief and in honoring what you lost. Many emotions exist behind grief, and I think this is really, really important. A lot of times in our life, people ask you, how are you today? And most of us give one emotion, right? I'm good, I'm sad, I'm happy, I'm frustrated. We are never experiencing one emotion at a time. We're always experiencing a bunch of them. And with grief, this is particularly the case. And a lot of the times when we're talking about grief that's a little bit different than maybe a loss of a person, that could be harder to recognize. It looks more like anger or sadness or frustration. And as we work with that emotion, we start to realize there's a lot of grief underneath there. And that's really what needs to be addressed if we're gonna deal with the other emotions closer to the surface. And therapists are really good at identifying that and getting to that. Grief is experienced repeatedly. So again, with chronic illness, just because you have a chronic illness doesn't mean you're not experiencing things like a death of a grandparent or a change in a job. And so it's important to know that you're likely experiencing more grief, and this is complex or compounded. And therefore, it's even more important that you're getting that assistance to cope with it. So what did it look like for me? Grief looked like the loss of favorite activities. So I've been water skiing my whole life before I went to kindergarten, and 12 years ago that had to stop, right? And swapping water skiing in a lake to, cooling off in a kiddie pool is a far cry. And every summer we go to the lake, and every time I get on a boat, I'm coping with grief. That grief is rising back anytime I'm on the water. And having to deal with that and find value even in other activities on the water can be really difficult. For me, it also looked like missed milestones. The secret is out because I'm here and I've told you about my job as a counselor, but for a long time I wasn't able to get to this point. It took me 12 years to finish what most people finish in about 8 years or even less. And so watching peers graduate and being in the audience, even though my heart and my mind were just as capable as them to accomplish those things. And that's a lot of grief to be behind. And it also included losing friends who were really dear to me. And Haley Royko was my best friend, and she was born a week before me. She was the first person I met with my same diagnosis, and she was a support person for me, which I think you can see here. The picture all the way on the right is one of my favorites at Muscle Beach. I had just had a major surgery, had a huge incision, and I'd sent her a message like, I can't go to the beach. I'm a freak. Everyone's going to stare at me. And she sent this picture in an email a few minutes later that said, we'll go to Muscle Beach because you're strong. And she had kind of photoshopped us, right, with everything showing. And so when she passed away, it wasn't just losing a best friend. It wasn't losing someone I saw myself in who was in the same position as me and therefore could be me. But it was also losing a support person. So how does therapy help us kind of process this grief? Well, it can look like advocating for making enjoyable activities that are possible, even if it means a lot of advocating. So for me, this looked like marching band. I've played clarinet my whole life, and I've been marching band my whole life. And when I went to the University of Iowa, I wanted to continue to do that. So the picture with the thumb up, I know it's hard to see, but I'm actually hooked up. I had my pump in one side of my breast pocket and the infusion bag in the other. And so I marched in front of a stand of 80,000 people while I was running an infusion of IV medications. And no one knew. And this picture was taken that day by someone out on the field. And so making this happen was difficult, right? The university had a lot of questions about, is that safe? How do we manage this? You're gonna be running onto the field. How does that work? My GI team was definitely concerned about it at first. Sterile things, dealing with pump beeps, all of that. It was hard. The easy thing would have been to say, that's just not possible now. And therapy helps you learn how to advocate for yourself, and they join you in that advocating process and say, hey, look, this is really important to her mental health and therefore really important to her physical health. We need to make this happen. It also looked like being supported and finding ways to make sense of the grief that I was experiencing. I have strong verbal skills and reading skills. It's what I do best, and I couldn't put it into words. And therapy really helped me look at other ways of making sense of this. And that included, watch movies, find quotes, look at music, try to find a way to express yourself. And one day I finally did through a song by Adele called A Million Years Ago. In listening to this song, I felt like I finally had a way to express what I was feeling like people didn't see me in the same light, were looking at me differently, feeling like every time I tried to achieve something, I was being held down. I wasn't able to achieve the greatest dreams that I had because of what was happening, and I couldn't express that fully. And I'll read a few of the lyrics because they really speak to me. I know I'm not the only one who regrets the things they've done. Sometimes I just feel it's only me who never became who they thought they'd be. I wish I could live a little more, look up to the sky, not just the floor. I feel like my life is flashing by and all I can do is watch and cry. So these moments of feeling like I just wasn't progressing like everyone else. And it didn't stop there, right? That was a pivotal moment for me, finding that. But what's important is being able to share that with the people closest to you. You already know what grief feels like. You're living it every day, but being able to share that with people who are supporting you is just as important. So I was encouraged in sharing that. And so I went to my mom one day, who's in the room, and I said, I just want you to listen to this song. Can we just stop and listen to this? And so we stopped and I played the song. We were silent through the whole thing. At the end, we looked up at each other. We were both crying. And that's all that had to be said. We didn't really talk about it. We hugged and we moved on, and we had this shared experience of understanding what my experience of that grief was, and likely her caregiver experience of seeing my life change. And that moment was super powerful in being able to kind of cope with some of that grief. And so therapy can kind of come alongside you and say, let's find a way to express that makes sense to you, because that's going to be different for every person. It also looks like finding ways to honor Haley. So Haley loved to make mini buddies. She made the ugly doll one there on the left for me after one of my surgeries. And she loved to make these for other people who are adjusting to these new devices. And although it's really hard to do this because supplies are so very limited, when I do have supplies, I love to do this. I made the mini one, and I love to make these and give them to kids. And every time that I do that, I feel like her legacy lives on, and I cope with her grief in that way. She also loved advocacy. So every time that I do something like this, I know that Haley lives on. And so finding ways that I can make her memory stand out is important, and we're doing that today after my presentation. And so moments like that and being supported in doing that is really powerful and helpful. So this is a difficult transition to kind of move straight to body image, but again, I wanted to address as many themes as possible so that hopefully everyone in this room sees something they're struggling with represented in this presentation. Body image just described how an individual sees their body, but also their perception of this experience and the emotions they're having at the time of feeling this way. It's closely tied to identity. That part we talked at the beginning, who am I? Is what I'm feeling on the inside and see myself as, is that being expressed in my outward appearance? It has a very strong connection to mood states. If you're really struggling with depression or really anxious, it's unlikely you're going to look in the mirror and be really satisfied in what you're seeing. And it's important to understand that relationship. So therapy has a lot of education on these types of connections so that you can start to look at it in a new way and see, okay, part of this is just, I'm dealing with a lot right now, and this is affecting how I'm looking at my body image and me and how I see myself. Trauma experiences, if you had a really traumatic procedure, getting a device implanted, and then you look at it day in, day out, and you're always using it, you're often being reminded of that. And the way you perceive your device and your body is going to be affected. Weight and scars are definitely a part of body image, especially when we're talking about nutritional support, but it's so much more. And I think often we focus on these more obvious areas and we forget everything else that comes below it. This can include, having a leak of a tube and it making your shirt wet and feeling like that's all anyone is seeing. Or maybe medication side effects like dreaded prednisone and the changes that causes, right? And so there's a lot of things that change the way we view about ourselves and how we feel about ourselves. It also includes this invisible illness bias, and I think this is really important because it seems kind of paradoxical. If you look healthy, if you look how society tends to want people to look, how can you have body image struggles? But if you feel remarkably different in how you're experiencing your symptoms and your day-to-day life and everything you do is interrupted by your medication and those things, then people telling you look healthy can cause a big shift in this body image and make you feel like you're not comfortable with yourself, even if you tend to look like what most people would say is desirable. And so targeting body image is just as important in these people. And of course, it greatly affects self-esteem and perception of value or acceptance by others. You can have a really strong support system, but if you're really struggling with body image struggles, it's going to be hard to accept that support. So again, seeing all the ways that these are connected and addressing them as a whole person, bringing them all together. So what did this look like for me? It certainly looked like being insecure with the reflection in the mirror. This is me on any sort of tube feeds. And distension is something I struggle with, and it looks like something else that can happen to young women, which is not always fun. I love to shop and clothing, but my pant drawer is also overflowing because I have multiple sizes of every pant that I own because I'm never exactly sure how big my stomach will be at the time that I need to wear it. It also includes trying to hide what was, in my opinion at the time, the largest peg ever inserted. I don't know if that's true, it felt that way. And learning how to hide that under clothing. For me, this comes up a lot, this idea of not looking like you're sick. In this picture, there's some evidence because the shirt I'm wearing is showing my line. But if my shirt was covering that, I don't think anyone looking at this picture would think there was anything wrong with me physically. The interesting thing about this picture is at the time it was taken, I was feeling really sick. And progressively through that day, it got worse and worse, and I ended up in the ER later that day. And I'll never forget kind of what happened when I got there. The doctor walked in the room and said something like, "Oh my gosh, we gotta get you out of here. You look way too nice to be here in the ER." Yeah, right? That was a really hard thing to hear in that moment, and I think he meant it in a really nice complimented way, and he probably saw other people in the ER who looked a lot worse off than I looked at that moment. He was shocked a few hours later when a rapid response was called because my labs were so atrocious. But I think it was a good lesson that what's happening on the inside isn't always obvious on the outside, and that even if you look healthy or look good in that day, you can still struggle with body image. For me, this also looks like how other people around you might respond. So I have a handicap sticker. I often use it because of my lung disease. You can't see my lungs. And I had a really terrible experience where I got out of the car and started to walk, and a group of people started screaming profanities, and "You should be ashamed of yourself. I can't believe you're using that." And I, to this day, often don't use the sticker when I should, to my own physical detriment, because I am afraid of that happening again. And that struggle of walking those long distances continually reminds me of the way that my body might not fit in with how other people perceive me. And sometimes this goes to the point I've caught myself at times, and this is terrible to admit out loud, feeling like I have to use it today, I can't make it, and thinking to myself, should I fake a limp so that no one says anything? And that's kind of a terrible thing to say out loud, but that's like the power of not being understood outwardly can have on someone's mental health, and just my wanting to go do things independently. I sometimes don't do things I otherwise would because I don't want to deal with having to use the sticker and people maybe questioning why I'm using it. This definitely extends to my professionalism as a provider. I put a lot of time and energy into my appearance more than anyone else. My coworkers are often like, oh, you look so put together all the time. It's because I'm masking something, right? I'm trying to make myself look as healthy as I can day in, day out, and that takes a lot of time and energy. And I'm often here, I can be a little more free about letting my line show a little bit, but I'm really focused a lot of the time on making sure absolutely nothing shows and that none of my symptoms are obvious. Don't wheeze, don't breathe too loud, don't let anyone know around you, especially the people you're working with, that there's something wrong with you. And that can enter my thinking in being a therapist in the room. I can worry about, did they see my dressing, and now are they gonna worry about me? And that can even lead to this spiral of thoughts where I think imposter syndrome, or why am I even trying to be a therapist? I can't do this. And so something as little as body image and being worried about that can spiral quickly into something a lot more. So how do we deal with this in therapy? Well, for me, it looked like changing my thought process, helping me to recognize that I'm having automatic thoughts that aren't necessarily fully true. So for me, this looks like thinking someone saw my line in a session, or having a leak in my tube and my shirt's not wet. And before I might have these automatic thoughts of, they definitely saw my dressing, now they know I'm sick and they're worrying about me. A therapist never makes other people worry. I'm supposed to take that away. Or they're gonna think I'm a slob and not professional. I mean, look at me, my shirt's all wet. And having to stop and kind of interject on those thoughts and say, I don't know why they're looking at me. I don't even know if they saw it. They're not gonna see a little bit of a dressing and jump to there's parental feeding. People don't even know that exists. And so interrupting those thoughts a bit and stopping them and saying, you know, I'm a better professional because I have this experience. And being able to use those thoughts to change that trajectory and get myself out of feeling like I should just quit and go home. So what makes a therapeutic relationship special? I want to kind of summarize everything I talked about today and really nailing this home. Because what it is it's that relationship that makes it work. And it's different from other support relationships. So it is that professional expertise we talked about, but really importantly, you continue to go through, like the presentation before me talked about, normal transitions, regardless of whether you have a chronic illness or not. And sometimes those, going from living independently to with others, and those challenges can be just as difficult. So we look at it from both sides, not isolating both of them. It's a safe holding place for thoughts, emotions, and distress. When we're with the people that love us most, we sometimes feel like we have to manage our emotions, or we can't say our fears out loud because we don't want to disrupt them or make them feel more upset. And so you're not going to do that with us. We do a lot of training on managing that and being able to take that on as that safe holding place of those really difficult emotions. You can scream at us as long as you're not saying you're a bad person. You can, if you swear a little, most people are okay with that. If you're expressing yourself in an appropriate way, you can cry as much as you want, and we'll hold that for you. And we'll experience that with you and tell you it's okay. We welcome support system participation. It's not one or the other. We want you to bring them in. And I think sometimes people feel, I have a really good husband or a really good, my parents were always there for me. I don't really need therapy. And I would argue that, okay, maybe you're getting by, but having another additional support is really helpful. And you can bring them into that process. In fact, we love it when that happens. We're not advice giving, so we are always being told what to do. We very much flip that on the head, sometimes to the dismay of people that come in. Just tell me how to feel better, right? And a lot of it is going, no, I'm not going to do that, right? And getting people to empower themselves. Because if you're empowered, your healthcare will be empowered, and you're more likely to meet your goals. Lots of interventions. If the interventions I showed today don't seem like they fit, like I said before, there's thousands more. So there's lots there, and we can really direct that to your identity, the components of you that make you who you are. And we're prepared for advocacy across systems. That includes personal advocacy, like bringing you together and saying, like me and marching band, and helping you advocate for yourself, and advocating with your treatment team. It's the power of that unique relationship, and I love that picture. I think it really shows well what that looks like. So I'm gonna go quickly through these. The slides will be posted later if you wanna return, but just kind of the tips for accessing therapy. Like the presentation before me said, talk to your providers, they can help you with referrals. You can also cold call therapists and they can help you with referrals. So you don't have to like go somewhere else first if that's really overwhelming. Call around. There's lots of financial assistance and pro bono services. Therapists spend a lot of time really fighting for social equality, and therefore have a portion of all of our clients that are either pro bono or sliding pay. So those spots are available, but they go to the people that call and ask for them. Explore online options like telehealth, especially if you're rural or you can't get out of the house or it's difficult to do that. And think about group options if financial is also an issue, because that does tend to lower the cost. And explore directories. So I love psychologytoday.com. You can go in, put in your zip code, the type of provider, even like I only want a female or I only want a male, and the issues you're struggling with, and then it's gonna pop out providers in your areas that are taking new providers. And above all else, remember that one size doesn't fit all. Anytime the power of anything is a relationship between two humans, not everyone is going to be a match. And so if the therapist you go to first or the therapist you've had in the past didn't fit, please, 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 I'm sorry for that bad experience, but I'm gonna say it over and over again, try another therapist. I myself have had things not work with clients I've had, and they switch to a coworker in my office and they do great, and that's okay. You're not gonna hurt our feelings. We want you to succeed and we want our time to be valuable. And so if it's not fitting, we would encourage you to find someone that's a good fit. So I'm sorry if you've had a really bad experience, and I'm really gonna encourage you to try to find another and have another experience, because I truly believe therapy is for everyone. Thank you.
I'm Lisa Metzger. I'm on the Oley staff, as people probably know by now. I want to thank Allie. That was wonderful. And thank Dr. Sivan Kinberg for her great presentation. It leads well into our next presentation, which is on In Loving Memory. We do it annually at our conference. It gives us an opportunity to pay tribute to people in our community who've passed away in the last year since our last conference and since we last did an In Loving Memory presentation. And I liked what Allie said. It's an opportunity to honor what we've lost. It's hard to be part of a community where you experience loss maybe more frequently than you might. But personally, I'll say it's a great honor to be part of this community, even peripherally, to know these people and to be part of that, and to, if you don't love, you don't have loss, right? So they come together. I'm gonna ask Dr. Howard to come forward if she's here, and Rhonda Ahrens. I've recruited a lot of people to help with this, and Joan. Joan is going to stand in the front with a pillar candle, and Dr. Howard is going to stand, maybe. If not, then Joan can do it. Maybe Roy would stay if Lynn doesn't come, or Beth, that would be great. There are candles on your table. We'll ask that one person from each table come up and light your candle from the pillar candle in the front, and then we will watch a slideshow, and Rhonda's going to share a poem with us. And we'll have a little music I'll come up at the end, and then it'll be time for a break. So, thanks.
Do not stand at my grave and weep. I am not there. I do not sleep. I am 1,000 winds that blow. I am the diamond glitz on snow. I am the sunlight on ripened grain. I am the gentle autumn rain. When you awaken in the morning's hush, I am the swift, uplifting rush of quiet birds in circled flight. I am the soft stars that shine at night. Do not stand at my grave and cry. I am not there. I did not die.
While that is very, very sad and almost painful, we want to recognize the contributions that all of the people that we lost this past year have given. Physicians, clinicians learn from every single one of you, and we should never forget that the very people we lost would want us to move on and live the best life possible. So, and now we found Dr. Howard, who has a few words to share.
We haven't had the roll, have we?
Yes, we did.
Oh,
But we're doing it at the end.
all right. So we learnt that Dr. Darling Kelly had died, and none of us had any anticipation of that. Darlene headed up the Mayo Clinic in Rochester for many years and was an ambassador on behalf of Oley to programs in Europe and Japan. Darlene truly embedded the concept that HPN consumers are captains of their own ships, and the role of the medical profession was simply to steady the sails. All of us who counted on her will miss her great sturdiness. The Oley Foundation honors her huge contribution and generosity.
We'll break. I want to thank Roy for the lovely music that we were able to listen to with that. And Rhonda for sharing the poem, and Dr. Howard and Joan. We'll break. We'll be break at now. We'll come back in about a half an hour, or 15 minutes, I'm sorry. And it will be set up like yesterday, where parental sessions will be on this side, and Entra will be on that side in Regency C. You can bring your candles on your way out. You can blow out your candles and drop them in a box, or you can leave them on your table if they're out. And thank you. We'll see you in 15 minutes.